Start recording though here. So welcome everyone. I think this is our last session together. In the formal sense, we'll certainly be welcome to set up additional ad hoc sessions if people desire. And you just need to message us to sort of set that up. We'll be happy to arrange some time. But we wanted to do a couple of things this last session, maybe just share some kind of unknown cases and let you see how well you do from the screen, describing what you see and where your differential might be. And then we'll take a few minutes for some feedback on how this process has been and where we can improve and what things worked really well. So with that bit of instruction or a little bit of preface, let me start by sharing a case from, we'll just share the screen here, from our teaching files. This is a woman with a vulvar mass. And maybe we could just call on Zudita. Would you like to just describe what you see and then talk through the case as you develop a differential diagnosis?
Okay.
You can't drive the slide, but I'll drive the slide and let you describe what you're seeing.
Okay. I see nests intrabacally of cells, blue cells, darkly stained cells, infiltrating into the stroma. And there
Okay.
is a hyperkeratotic kind of lining epithelium, I think.
So how would you describe the architecture?
I couldn't appreciate the higher power view.
Is it forming glands or sheets, nests, or cords?
Louis, I'm sorry, what organ system did you say this was?
Oh, this is from the vulva.
Okay.
The vulvar mass in an adult woman. I don't remember the exact age.
Okay.
Looks like solid sheets.
Yeah,
rather than glands.
at least there's some small cords. There's maybe this might be a gland right here. Yeah, but mostly solid sheets.
Some glandular structures, I don't know, or follicle-like structures.
Uh-huh. So what would you like to do to work this case up?
It looks like to have a neuroendocrine nuclear feature.
Yeah, so with the cords, I think neuroendocrine is a consideration. Not very common in the vulva. What else might you think about?
Merkel cell.
I'm sorry, could you say that again?
Merkel cell carcinoma.
Okay. Anything else?
Breast.
Oh, very good. So I think
carcinoma rising from the ectopic breast.
Yeah, sort of ectopic breast type of tumor. Could easily have this type of a pattern. So markers that you might include for breast carcinoma, like GATA3 and ERPR and so forth. So that actually is the diagnosis in this case. It's a mammary type of carcinoma occurring in the vulva. And sometimes that can throw us off. The other things that I think come into the differential sometimes are less common, like Skene's gland adenocarcinoma, quite unusual. Melanoma, of course, might have a solid and infiltrative pattern like this as well, but usually would have a surface component. This didn't have much of any surface component. As we come back to low power, I think you can see we just have fat and solid tissue, and there's really not a surface element to this. Any other thoughts on this case, Vanita?
Yeah. Can you hear me?
Yes.
I'm hearing myself twice over, so can you hear me still?
So your phone and your video are, I think, both picking up the sound or putting out sound that's
I think your iPhone audio is better than your computer audio. So if you mute your computer and maybe just try to talk through the iPhone, that might be best.
Okay, can you hear me fine now? Okay, so
Yes.
I think the two other differential diagnoses that I would throw in is obviously a metastatic lesion to the vulva. I guess I certainly have not seen a breast metastatic to the vulva, but just generally speaking, if it is undermining the epithelium and not arising from the epithelium, then that's one consideration. The other thing that I would throw in is an epithelioid sarcoma, because those can be epithelioid looking, but it doesn't quite look like that.
Yeah, that would be the very cellular types of epithelioid sarcoma.
Yeah, I'm just, just as a different sort of a outside shot that it would be a consideration, but I agree with you that it doesn't really look like that.
Okay, very good. Any other questions, Zuditu, on that?
No.
Okay, well, let's go on to another case here. And this is an ovarian lesion. Aisha, are you on? Or would you like to discuss this case?
Okay,
It's a
I'm
low
back.
power view.
Okay, so this is I think a 35-year-old. No, this is an older. This is a 30. Yeah, no, it's a 35-year-old woman, and she has some abnormalities in her ovary, as you can see. So I'll let you sort of describe what we have here from there. Aisha, you're muted. We can't hear you.
Oh, sorry. Yeah, I see a solid lesion, solid type of lesion with adjacent calcification. I couldn't appreciate the nuclear details of the solid component. Yeah, looks like this germinoma type.
Okay.
Yeah. Well-rounded, uniform cells, and with stromal inflammatory cell infiltrates.
So what do you make of these calcified areas and the stroma out here?
Sorry.
A little bit more. So what do you make of these calcifications?
I mean, what's the cause of this calcification, you mean?
Yeah.
It's a kind of dystrophic calcification.
Okay, could be. Could be.
Mhm.
Let's look a little further and see if there's any other clues here. It's been a while since I looked at this case, so I don't remember exactly what all is here.
Internet apa?
I have a very terrible connection. I'm sorry.
That's okay. That's okay.
Yeah, I missed some of your uh, talks.
So I'm trying to remember this case. I just looked at it cold. I just got back from traveling, and so I didn't have a lot of time to go through and review these in advance. So I think this is a patient who has a sex cord tumor with annular tubules and then an accompanying dysgerminoma, as you've described. But I'm having trouble finding the sex cord the annular tubular component here because we've just got so much of this calcification.
Louis, I was wondering, it wasn't a gonadoblastoma, because I guess what I was thinking is that this dysgerminoma is perhaps arising in a gonadal dysgenesis, which often has gonadoblastoma, which tends to calcify.
Yes, you are right. You're right. That's the history. Now it's coming back to me. But
Okay.
it looks a lot like dysgerminoma because of the
That's all dysgerminoma, but I was thinking that the gonadoblastoma often calcifies, and so finding a viable tumor is often a challenge. So I was thinking that that's what the calcified areas might be.
Yeah, I think you're right, and that's exactly right. And that's how the case I think came together. So talk more about that while my memory is being restored.
So does that mean, if we don't find the other tumoral lesion and if you have calcification, this abundant calcification along with this dysgerminoma, we can make a diagnosis of gonadoblastoma?
Yeah, so it would be, dysgerminoma arising in gonadoblastoma, it's the dysgerminoma that is the malignant component that drives the patient management. And patients who have a fragment of Y chromosome in their tumors, they are at higher risk for getting dysgerminoma arising in gonadoblastoma. And so those are the patients who actually undergo prophylactic oophorectomy. And in fact, all patients, my understanding is that all patients with Turner syndrome have to be checked for a silent Y component to determine what their management is.
Yeah, I think they put this together as that sort of a case with, and I think this is the comparison of a more diffuse and actually a frozen section sample from a dysgerminoma. So yeah, very good. It's coming back here slowly.
So
this is the size of this is a real critical thing. I mean, you wouldn't expect this size of an ovary in a younger patient, which this was. And so it's a dysgenetic ovary with this foci of dysgerminoma, making it a gonadoblastoma. Yeah.
Yeah, I think the major recent advancement has been that, I think up to 20% of Turner syndrome, which is typically XO, are actually mosaic XO and X with a portion of the Y chromosome. And those patients are particularly high risk for developing dysgerminoma. It's a beautiful case. Thank you.
Well, I do have some good slides in this collection. So let's stay a little bit in the germ cell realm, and Dr. Benson, would you like to discuss this case? I see he's on, but I'm not getting a response. Dr. Benson? Macharia? Well, in that case, Dr. Partey, could we call on you? There's two non-responses here. Dr. Desalu, would you like to take this case to discuss? Boy.
I can take it.
Okay, please be my guest. This is again a younger patient, 30.
There are nodules of structures, nodular structure with. I can't appreciate the high power, but at a low power, there are some small cystic or follicular-like structure containing secretory material. Okay, you can see that there are some nests, and some secretory kind of mucinous material, signet ring-like cells as well, and some glandular structures with nuclear atypia, pleomorphism, and mitotic activity.
Yep, there's a mitosis there.
Yeah. This is an ovarian massia.
Yes,
Yeah.
This is from the ovary. Very good.
So this could be either a secondary adenocarcinoma or primary signet ring cell carcinoma, or the other differential will be probably yolk sac tumor can be considered as a differential.
Yep.
What would be the most useful thing to help you distinguish those?
Yeah, I mean the immunohistochemistry or the morphology?
Yeah, or
I can't.
even just clinical findings. We've said
Yeah.
she's a younger patient. That's a helpful factor, right?
Yeah, age, of course. I can see that there are some glandular structures, some strands, nests, and a background myxoid stroma. Probably yolk sac tumor will be top.
Yeah.
Yeah, so the clinical finding that would be most helpful to know before you got this as a frozen section or something would be a serum alpha fetoprotein. And
Do we have some hyaline globules here?
Yeah.
yes, we do have hyaline globules in this case. Here's maybe some more over here. Now, I don't think we've seen any characteristic Schiller-Duval bodies. Should that bother you?
No.
No, you only see those in a small percentage of cases, even though they are quite helpful if you find them. Not finding them doesn't exclude yolk sac tumor. Now, architecturally, there are several different patterns that yolk sac tumors can have. And those include names like the polyvitelline duct pattern, the hepatoid pattern, and then this more sieve-like, lace-like pattern. Do those patterns have any significance? Should you report the pattern?
I don't know.
Yeah, there is some evidence that maybe some of them do, but it's not a requirement. It's not a part of the checklist or anything like that you need to say this is a hepatoid yolk sac tumor or something. The only thing to be aware of them for is because it's sometimes those two patterns, the polyvitelline duct pattern, which is larger cysts, and this pattern with the hepatoid pattern can be harder to classify as yolk sac tumor, especially if those are the predominant or only pattern that you have. Benita, do you want to make any further comments?
No, I think you pretty much said it all. The only other comment that I'll make is that the solid pattern is the one that looks most like dysgerminoma, and then they're both CD117 positive, so that can sometimes throw you for a loop. But other than that, you said everything.
Well, what immunohistochemistry would you do on this, if assuming you didn't have the AFP in the serum?
I mean, Glipican is positive. PL, I guess, it depends on what the differential diagnosis is. So if embryonal carcinoma was the differential, then CD30 should be negative in yolk sac, positive in embryonal carcinoma. Glipican, CDX2 can also be positive in yolk sac tumor. CD117, PLAP. I don't know. Am I missing out on what are you thinking about?
No, I was just curious in terms of how you would what workup you would do, if any, on these tumors. We have kind of a standard list of what we do on serous carcinoma, but in germ cell tumors, I think it's less strictly defined as to what you absolutely need to do to make a diagnosis. And
so I guess if the patient did not have an AFP elevation, I would be concerned that I was missing the diagnosis. And so therefore I would do a battery of stains, because yolk sac tumor invariably has actually very high levels of AFP. So that would be truly unnerving to me. But PLAP, CD117, CD30, though I've never seen an embryonal one look like this.
no, I haven't either.
Yeah.
We had a case not too long ago where the diagnosis of yolk sac tumor was made in a postmenopausal woman. And in that setting, I think that very, very possibly they wouldn't have done preoperative serum markers for AFP and so forth.
Right.
What experience do you have with older patients with yolk sac tumor?
So those are the ones that are classified as somatically derived yolk sac tumors. And so they're not true germ cell tumors. And the one big difference between the somatically derived and the germ cell associated tumors is P53. So P53 is typically positive in the somatically derived germ cell yolk sac tumors, which is typically negative in the germ cell derived tumors, and molecularly those tumors will show the typical profile of epithelial tumors. So, molecularly, this should have a chromosome 12 abnormality, typically isochromosome 12p, if this is a germ cell derived, but not if it is a somatically derived tumor.
All right. Anyone have any questions you want to bring up about germ cell tumors? We've had a couple of these, and I know we don't see a lot of these all the time. So it's, I think, helpful to share experience. But any questions anyone wants to bring up?
Yes, I have one question.
Yes.
It's just on choriocarcinoma. Is that possible? Choriocarcinoma, endometrial choriocarcinoma.
So what's the question?
The question is choriocarcinoma endometrial in a postmenopausal woman. How do you explain?
So again, I think it's the same thing. So choriocarcinoma, you can have trophoblastic differentiation in epithelial carcinomas, and those will have elevated HCG and look like choriocarcinoma. But those are also somatically derived. They are not germ cell derived choriocarcinoma. So they will have all of the features of choriocarcinoma. They're typically not that large, and they typically associated with other epithelial components like, endometrioid carcinoma or even serous carcinoma. But you can get them in elderly patients. But they're somatically derived as opposed to germ cell derived.
So in that case, are we going to call them endometrioid carcinoma or non-gestational choriocarcinoma? How can we just name them?
So you would call it choriocarcinoma. If there is an endometrioid component, then that's, I think, proof positive that it is somatically derived. If you don't have a somatic component like, either serous carcinoma or a carcinosarcoma or an endometrioid carcinoma, then you would call it choriocarcinoma. For choriocarcinoma, my understanding is that they are exquisitely responsive to the, gestational trophoblastic disease chemotherapy, which is either methotrexate or EMA-CO. So you would still call it choriocarcinoma, absent genetic testing to demonstrate that it is gestationally derived. I don't know. I think the diagnosis remains the same. You would have a hypothesis as to whether it's gestational derived or not. I've seen one case of a choriocarcinoma in a 50-some-year-old woman, but the patient was not menopausal, so she was still cycling. And that was gestationally derived. It had a different genotype from the mom.
Thank you.
Okay, good question and good discussion. I'm learning some things here too. So I have a couple of ovarian unknown cases that I have shared with people, and I'm not sure if we did some of these previously, but I thought we would do one or two additional cases. Dr. Yukikwe, are you available to discuss this case? You're on the call. Can you hear me? Dr. Ukikwe, Francis Ukikwe?
Hello. Good evening, all.
Hi.
Thank you.
I'm sorry. I'm actually on transit.
Oh, so not a good time to discuss or to discuss.
I'm just listening in. I'm on transit, but I'm just listening in.
Okay.
I'm actually driving.
Don't.
Okay. No, don't look at slides then.
Okay, I'm sorry. Thank you.
Okay. Aisha, would you like to do another one?
Maybe Dr. Desalu?
Yeah, the problem here is I'm following with a mobile phone.
Ah,
I
okay.
can't see the details. Yeah.
I
Okay.
see.
Sorry,
Same is
sorry for
here.
that.
I'm using my mobile. Yeah. Can you give me a little bit of history, Dr. Lewis?
So this is an ovarian mass, and actually, this is, I think, the same case that we just discussed that has another area.
Yeah.
So let's
Yeah.
go to a different tumor. Okay, so this is an adult woman with modestly enlarged ovarian mass and normal serum markers before surgery. I think she was in her 50s. So what do you see here?
Partially cystic and partially solid proliferation.
Okay,
Deeply
sitting
blue.
solid.
Yeah. So I'm not focused with solid things. Can you give me a higher quality?
Yeah, I'm trying to find a good area here.
Yeah, I'm looking on round cells with dark, with hyperchromatic nuclei. Kind of some big granular structures
Okay.
or slit-like structures. Hyperchromatic is kind of prominent nucleoli.
You see a sort of a uniform cell type. You see a mixture of cell types here.
I think it's a mixture of cell types. One has light abundant cytoplasm, eosinophilic, and the other is a little bit darker.
Yeah.
So what does that make you think about?
Let me figure out.
So you've got sort of cystic or tubular structures and then an interstitial mixture of cells with very uniform round nuclei. What category of tumors are you thinking this might be in, given that morphology there?
Kind of sex cord stroma.
Very good. Very good.
Yeah. Sertolyladic cell tumor, I'm not sure.
Yep.
Yeah, very good. You hit it out of the park. Look at that. And is this a well differentiated or a poorly differentiated one?
Well differentiated.
Yeah, it's in the well differentiated side of things. Not any spindle cells and ample numbers of Leydig cells along with it. So are there any genetic syndromes or anything you should be thinking about in a patient with a Sertoli Leydig cell tumor that might impact their prognosis or other workup that they might get?
Kind of testicular feminization syndrome, association with testicular feminization syndrome.
Okay. Anything else?
I'm not sure.
So some of these patients have a Dicer1 mutation, and that can be associated with other abnormalities in other organ systems. And so sometimes that is also important to bring into consideration. I know many places in the developing world, you won't have access to, that kind of mutational testing. But being aware of that association can at least alert people to consider that possibility clinically and look for some of the clinical signs of those other elements of the Dicer-1 syndrome. And I have to look those up every time. Benita may have them memorized, but I have to.
Okay. I mean, they can get thyroid neoplasms, renal neoplasms, and brain tumors. The only additional comment that I would make is that the patients who are syndromic often can have bilateral tumors, and the bilateral tumors are not metastatic. They are bilateral synchronous tumors, and that's important to know because otherwise they get upstaged. They do not need, if they have bilateral tumors, unlike the sporadic ones, which you would assume are metastatic, in syndromic ones, there's good data to show that they are synchronous independent tumors. So they're two 1A tumors rather than individual tumors. The other thing with the syndromic tumors is that they often have a gynandroblastoma-like appearance with areas that look like juvenile granulosa cells. So that's another sort of hint that it might be arising in a patient with a germline Dicer mutation. And I think we're moving towards a thought process that where you have a gynandroblastoma that is juvenile granulosa cell with Sertoli-Leidig, that those are actually pure Sertoli-Leidig tumors simulating granulosa cells, and they behave like Sertoli-Leidig tumors. So,
yeah,
like extra stuff, rare. All of those, we're in the extremely rare camp now.
Yeah, well, this is the last session of the year, so we have to give you the advanced topics, I guess you'd say.
Yeah.
But sort of with that, let's take the next 15 minutes or so, if we may, and just sort of discuss a little bit about how this process has worked, what things you have found very helpful, and what things you would like to see improved or changed. With that discussion, or with that caveat, I'd also like to ask the question of one of the proposals, one of the considerations we have going forward is, should Open provide a certificate of some degree of competency in gynecologic pathology, having completed the online modules and participated in most of our mentoring sessions online that are live. So that would be the first question. Would a certificate of special competency or special accomplishment in gynecologic pathology be helpful for you in your practice situation where you are? If you can't talk, maybe you can just put a comment in if you're not able to do otherwise. But that's the first question.
Yeah. Okay. Yeah, I think I can answer.
Yeah.
We all agree that it's very helpful. One, it's very encouraging to continue to the next module. And the other thing, as you said, it just helps to have a certificate of competency in GYN pathology for our practice as well.
Okay. Anyone else agree with Aisha?
Yes, I agree. It will be significantly helpful for our practice. Definitely.
I think ultimately what we would like to do, if we have the funding to do so, is when someone has completed a module like this, or the three modules on Open, and the three courses, and also participated in these sessions, we'd almost like to come and do a site visit, if you will, and present your certificate in person if we could, but also just to see your practice and to provide some additional encouragement in that regard. Of course, we hope that will take a fair number of mentors willing to travel and so forth and put that in. But would that kind of additional recognition help you in your practice, or be an imposition or problem? Helpful, not helpful?
It's definitely
That's
helpful.
very, yeah. Mm. That's helpful. And if possible, I had a chance to go to US last time for about a month ago, and it helped me a lot. Yeah, it helped me a lot. I mean, to be under the mentors' participation. So for you to come, that will be, I mean, very fine. But if there is an access, one of my colleagues or two of them, if they can have the access to come and visit your institute, that will be a good, I mean, practice, a good opportunity to see what you are doing, or what the advanced labs are doing.
Good, good. So for those of you who may not have yet completed the 3 modules, and I think that's most everyone still quite, I haven't checked with Abby whether we have anyone who's completed them all. I would say if you can complete those within the next 3 months of having finished this course, we will make sure that we find a way to get you your certificate of completion and competency on that as well. What parts of the experience were the most difficult or problematic? I know we had some problems with connectivity and so forth. Any other, what else, what other kinds of problems did you encounter in terms of either the virtual materials or these mentoring sessions?
In my part, I don't see any difficulty except time constraint.
We are going to have our monthly session, at least for that.
Well, thank you everyone for this excellent feedback, and thank you for participating today. I know it's hard to describe things on the screen, on your phone, while you're traveling. When someone else is driving the slide, those are all handicaps, but you did very well, and it's very heartening for us to see the great progress that you're making. And we realize that it's an ongoing process, and we always want to continue to build that. And as I tell my trainees, pathology is very much a team sport. It's a collaborative effort. That's true on the research side. It's true on the clinical care side. It's true on the education side. And so this is a nice example of that. And I hope that you'll continue to field questions with one another as well as with us. You are that's how we gain our experience and further the process. So this is what we'll continue to do. But I think we've made a very strong step forward, and have continued opportunities going forward. So again, thank you so much for participation, and we will set up the next session with Abby's help for sometime in January. And with that, with the responses that you give her, please also indicate, kind of whether you're whether you're willing, or how you're willing, how often you're willing to share a case in those sessions, and that will help us to sort of assign frequencies and work out the details of that case sharing for you going forward. So with that, have a wonderful evening, wonderful afternoon. Thank you so much for a very productive session.
Thank you. Thank you.
Thank you, and happy holidays, everyone.
Yes,
Thank you.
happy
Thank
holidays.
you.
Merry
Bye.
Christmas.
Thank you.
Bye-bye.